So hello everyone. Thank you for tuning in to our panel discussion on universal lung health today. My name is Prashant Warrior and I'm the founder and CEO of Qure.ai. Over the past 3 years, COVID has claimed approximately 59 million lives. But in 2020 alone, another pandemic infected 102 million people, 102 million people, resulting in 1.5 million deaths. It's not only the deadliest infectious disease in the world, but also seems to be the most silent one. I'm referring to tuberculosis. And that was 10.2 million, not 102 million. During the same period, lung cancer claimed approximately 1.83 million lives, with 80% of cases diagnosed in later stages, leading to negative outcomes. I felt the need to make the above points because tomorrow is World TB Day. It is a good time to remind ourselves of the continuing struggle to combat TB, the oldest infectious disease, while dealing with other pandemics and non-communicable lung diseases. Having worked with frontline healthcare professionals for the past 5 years to eradicate TB, Qure.ai has a significant stake in the fight against TB and other lung diseases as well. For today's discussion on how we can achieve universal lung health, I am honored to introduce our keynote speaker, Dr. Machika. Dr. Machika is the Executive Director of the Stop TB Partnership. She has been instrumental in developing a clear identity for the Stop TB Partnership, ensuring a strong voice for the TB community in the international arena, and being a great advocate for all those marginalized and vulnerable due to TB. Dr. Machika is a strong believer in innovation and change, is restless in pushing for more ambition in TB work and challenging the status quo. She and her team have partnered with Qure on various public health projects across multiple geographies. She could not be here with us today, but she has shared a message for us all. Log into Zoom.
Hello, everybody. It's such an honor to speak today in front of you. A bit less exciting as we are not able to meet each other in person yet. And a bit less exciting because I have this recorded message that is sent to you, but stay reassured that I'm saying exactly the same things as I would have said them if I was in person. I'm very grateful to Prashant and the team from Qure.ai for putting this event in place. My name is Machika. I'm the Executive Director of the Stop TB Partnership. And in the Stop TB Partnership, we are located in Geneva, Switzerland, and a partnership that hosted by United Nations. We try hardly to end TB by 2030. You see, the theme of World TB Day this year is Invest to End TB, Save Lives. And this comes from the fact that in TB, the resources that are available, both for research and development, as well as for implementation and rollout and scale up of efforts, are completely insufficient. Because a lot of this work was done by, doctors, nurses, healthcare workers. People tried to do their work without making too much noise about the lack of visibility and finances in TB. And we tried always to achieve as much as possible with the money that we were having. It is a time when enough is enough and you really cannot take it anymore. And I think this is now. And it's time to say the truth, to say the numbers, and to show people that when you try to achieve 100% of the targets with less than 40% of the funds, it cannot work. So here comes our minds, and if we want to be innovative, and if we want to be opportunistic. And that comes from the fact that reality is that in the year 2022, very few will really put money just to fight TB. Reimagining TB care is once you get a person that is receiving a service, why not make it for several other diseases? Isn't it much easier for all of us that once we go for a checkup, we are checked up for several other things? It is. And this is what we spoke about in our efforts. And I know that in TB, for example, we know about the TB, HIV, and to a certain extent, diabetes integration that we were trying and pushing a lot. And this is also what we were trying to speak when we started looking during COVID about the bidirectional testing. Once you have somebody that has some symptoms that are somehow similar for TB and COVID, it's much easier to test them for both. and see what is going on. But we can go even further. And I'm very happy about the conversations that we have right now in using X-ray portable machines and artificial intelligence to screen people for TB. But once you do an X-ray, you can diagnose, and those of you in the room and my fellow panelists will speak about this much better than me. You can look at other lung diseases as well. I'm a pulmonologist, and we all know that you can discover a lot of things during an X-ray. It can be TB, but it can be another type of pneumonia, COPD, it can be a cancer, it can be advanced form of fibrosis, it can be many things. So once you have the possibility of screening people, you have the machine and you do X-ray, why not do it at mass? And then you screen out all these different diseases. You do a differential diagnosis. We have now artificial intelligence that can read this better than the eye of the people. I'm not saying this that everywhere radiologists or clinicians should be removed, but I'm saying that in this kind of effort in which you go at the lower level and in the community, that's the perfect algorithm to use. And wouldn't it be amazing to be able to go and screen and identify even cancer in the early stages and be able to direct the people to the right diagnosis and to the right treatment early, not wait till the last moment, which is happening in so many instances. So the discussion today is about innovations. There are a lot, and there'll be a lot coming up. There will be apps that look at the cough, and you cough in your phone, and then based on that, there can be an assumption of what kind of disease you have. That we have more portable X-ray machines and artificial intelligence, so it's absolutely possible to have the people being diagnosed or screened for X-ray and then further diagnosed. This is an amazing gathering here of artificial intelligence providers, developers, organizations that are basically pushing the boundaries, universities, and I know that the meeting will be extremely uplifting. I just hope that we will continue in the same uplifting way as it goes, because we really have to end TB by 2030, and we know it is possible. It will just request that we are very smart, agile, and innovative. Thank you very much.
Thank you, Dr. Machika. It's always great to hear from Machika. She is always very inspirational whenever she talks about TB and other lung conditions. So thanks for that. I will come to the other panelists. I wanted to introduce everybody, and I'll sort of introduce one by one, and then maybe I'll introduce everybody, and then we can sort of go through, and if everybody can talk about for a few minutes about what you're doing in your organization and what are you focused on from a lung health perspective, right? So I'll introduce panelist Dr. Morten Roald leads the TB program at FIND, a global NGO that focuses on providing quality diagnostics. Morten oversees a large portfolio of developmental projects, including molecular assays for TB detection and drug resistance detection, digital diagnostics, and AI-based tools. Dr. Pei Fong is the head of oncology and international medicine with AstraZeneca. She leads more than 80 countries in oncology within medical affairs. She predominantly focuses on innovation within AstraZeneca's international medical team, leveraging advanced technology and synergistic external partnerships for patient care. As you probably know, AstraZeneca and Qure.ai have been partners for almost a year and a half, focused on improving early detection of lung cancer using AI. Dr. Roland Dilling is the Chief Medical Officer and Director of International Public Sector Health for Amazon Web Services. He is responsible for healthcare strategy and operations for AWS internationally. He is passionate about the delivery of person-centered care and improving outcomes at a lower cost by accelerating the digitization and utilization of healthcare data. Dr. Yogan Pillai is the country director of CHAI in South Africa. CHAI is Clinton Health Access Initiative. He is responsible for policy making, guiding implementation, and monitoring of national programs on HIV, TB, and maternal, child, and women's health. He's also currently facilitating the implementation of a national program to re-engineer the primary healthcare system in South Africa. Dr. Pillai is a co-author of the textbook International Health, Global Health in a Dynamic World. Great to have this esteemed set of panelists on board. And I wanted to start with Dr. Pillai. If you could talk about what you're doing at CHAI and how you focused on lung health specifically.
Great. Thanks, Prasant, very much. And thanks for the invitation. I hope you can hear me. Yes. So I started my career in the Department of Health as somebody who was focusing on the health programs, and TB was one of them. So I have a long history of running the national TB program in South Africa. Currently, as you said, I am the country director of the Clinton Health Access Initiative in South Africa. And we're focusing on a few things. The first is to help the department to roll out 3HP to ensure that we can prevent as many people from contracting TB as possible. With a very large cohort of HIV positive people in South Africa, it's very important, and of course with other immunosuppressed diseases, it's very important for us to ensure that we prevent TB. So rolling out prevention programs on TB is quite important. And we're quite lucky that we now have 3HP. It's moved from single pills to a fixed dose combination, making it easier for patients to take. And we need to figure out, how best to get 3HP to those that are at high risk for contracting TB. For example, those that are HIV positive, as well as contacts of TB patients. Secondly, we are assisting the department to find about 150,000 people with TB annually, incident TB annually, who do not get diagnosed and are not on treatment. And of course, this means that these 150,000 people will be transmitting TB to other folk, on average 15 other people in a year. So it's very important that we do the case finding, find people early, put them on treatment, and ensure they're cured. That's with respect to drug-susceptible TB. And then finally, with drug-resistant TB, we've got in South Africa a fairly large number of people who have drug-resistant TB as well as extremely drug-resistant TB. And again, moving to shorter duration treatment, diagnosing early, ensuring that people are diagnosed, put on treatment, etc., are fairly critical. And then the last thing we're doing is we are trying out new diagnostics. It's very important in the South African context because we have a high initial loss to follow-up of patients to ensure that we have these rapid diagnostic tests for TB, pretty much like we have for HIV, to ensure that patients who have symptoms of TB can be quickly screened and diagnosed. So we're very impressed with the initiatives to have handheld portable X-ray machines that we can take into clinics, small clinics, into communities to do the screening and then get sputum to diagnose people. And we would like to see more and more multiplex lab instruments at clinic level so that we can do a number of tests using the same lab platforms. And we think that in that context, AI is going to be a potential game changer, reducing the distance between where we see patients, the lab, as well as experts, because not all our primary care clinicians, are well versed, especially with treating XDR, MDR, and XDR, for example, and of course the cancers. So I'll leave it there. Thanks very much for the opportunity.
Thank you, Dr. Yogan Pillai. I had a quick question on this, right? So when you are doing these, when you're trying to detect incidental findings, incidental TB, what is the typical protocol that you follow?
So, at the moment we are using the symptom checklist, and we know that the symptom checklist is not very sensitive and specific. And that's one of the reasons we think, an X-ray will be a good idea. And one of the things we are currently doing is also looking at people who have been contacts, HIV positive, anybody who is at high risk for TB, for example, people who smoke, for lung diseases, should be screened for either lung disease or specifically for TB. we're now trying out a new technology, which we've tried out with COVID. We've had something called COVID check. So you download a set of symptoms on your phone and you can respond to it's an app basically. You respond to that and you get referred on to a facility if you screen positive on in terms of the symptoms on your phone. We've now developed out of that TB check with the Gates Foundation, and our ambition is by the end of this year to have about 1 million people checking their symptoms on their phones. And we think the yield to treatment, not just to diagnosis, to treatment could be around 8,000, between 8 and 10,000 people that we would find in a year by using TB check. So we're trying to kind of get these devices into people's hands so people can look after their own health, and so that they don't always have to come to a facility to be screened. Thanks. Over to you.
So thanks a lot, Dr. Pillai. I think that's a very, very huge contribution, because as we all know, a lot of TB cases are detected very late. People have to go through so many steps before they finally get diagnosed with TB. And being able to find those cases early, being able to find those cases as incidental findings and so on, it's a great achievement, and great to hear from you about that. Dr. Morton, on to you. Morton, so you have, I think if you wanted to quickly talk about what you are doing at FIND, and maybe you can sort of spend a couple of minutes on that.
Yeah. Thanks. Can you hear me?
Yes.
All good. Great. Yeah. So FIND, we're an NGO based in Geneva, and we're working on sort of the full value chain of diagnostics from early development up to access work. We're also the WHO Collaborating Center on diagnostic test evaluation, and we have supported a lot of basically all of the diagnostics for TB that have come through the pipeline in the past 15 years. And for many, TB is a chronic infectious disease or chronic lung disease that kind of develops over a long time. It's treatable, but for many, there is no access to the diagnostics simply because they are too complicated. So if we could get something earlier diagnosis, useful at the point of care, I think we could close the detection gap, but definitely also prevent sort of much of the post-TB lung disease that many patients unfortunately are suffering from, basically because this is such a complex disease. So at the moment, we're focusing a lot on earlier diagnosis, and we are very inspired by what has just happened with the COVID pandemic, that big shift that has happened there. So we're working on non-sputum-based point-of-care molecular diagnostics and highly sensitive urine-based TB detection assays, the CAD and the chest X-rays, and basically all the way up to really complex, extensive drug resistance detection panels using next-generation sequencing. So basically, we try to be everywhere when it comes to diagnostics and diagnostics for TB.
Thank you so much, Martin. Roland, do you want to go next?
It'll be a pleasure, and thank you very much for the invitation to speak on this great panel. So my name is Dr. Roland Dilling, and as you said at the beginning, I'm the Director and Chief Medical Officer of AWS, Public Sector Health International. We have at AWS a healthcare mission and strategy. So our mission is to enable access and delivery of person-centered care to improve outcomes at a lower cost by accelerating the digitization and utilization of healthcare data. And I think that piece about the beginning is the enablement piece is really critical, because we really want to support groups like FIND, like AstraZeneca, like CHAI, to do that last mile piece of delivery to patients in the field, while we can provide the cloud infrastructure to democratize access to both all the data that's being generated and all of the compute power that's required, not only to develop some of these digital tools like AI that was mentioned, but also to actually put that AI closer to the patients themselves, to really put it in the hands of the care workers in the field, and to enable them to use these tools and to bring that specialist lens right down to the patient level where maybe specialists aren't there. And I think that's why it's very exciting to join the panel today, because I think there's a great work that Qure has been doing to really enable that. So the Qure analytics piece in the cloud, how can we democratize access to a tool like the Qure.ai to really go down to the patient level? And an example from COVID, for example, not specifically related to TB, but this is during COVID, we supported a project called RADVID-19, which was done in Brazil. And this was done through the Hospital das Clínicas Innovation Center in partnership with the government. And they realized they didn't have specialist radiologists in the hospitals around Brazil to make the diagnosis on the chest CT scans. And so a network was set up where the local hospitals could upload their CTs onto the network. And within 10 minutes, it would be reviewed by 2 different AI algorithms, and a report would be generated and sent back to the local hospital, to the local clinician, with a report giving a likelihood of COVID and actually a segmented scan showing where the disease actually was. So I think the power of that to really affect change on the ground is critical, but it's that last mile delivery which is really, really important. So I think there's much more to discuss around TB in particular that we can go into shortly.
Thank you, Roland. I think the role that AWS is playing in all of this is tremendous, right? Getting access to all these different geographies where you may not have the compute power to process an X-ray or process so many different disease scans, right? I mean, for example, CTs in this case that you mentioned. So I think it's amazing, and we'll discuss more about this. Peche, do you? I think people are keen to hear about what AstraZeneca is doing in this space. I think somebody already asked if you are. I think Dr. Pillai asked if you are producing a vaccine for TB. We'd love to.
Yeah, I don't know if I can comment on that, but I can share what we're doing in the lung cancer space and how we're going to cooperate with the TB organization. So as Prashant has said earlier, that I cover the international region, which is 80+ countries. We don't cover US, Canada, EU, China, Japan, but pretty much everywhere else in the world. So, and many of those countries that we cover in Asia, Latin America, Middle East, Africa, are low middle income countries. So as you can imagine, to try to solve kind of ecosystem problems can be sometimes very challenging for us. So at AstraZeneca, lung cancer is one of our top priorities in our cancer portfolio. We have 2 very important projects at AstraZeneca that's related to lung cancer that we've been able to leverage. One is the 8 Catalyst Network. It's created now as a global program at AstraZeneca that focuses on the identification of innovative approaches and innovative solutions to ecosystem problems and also pain points within the patient journey. It is through this initiative that we got to meet Qure.ai. So we're very much benefiting from this program. The other is Lung Ambition Alliance. It's a partnership between Global Lung Cancer Coalition, Guardant Health, the International Association for the Study of Lung Cancer, ISLAC, and also, of course, AstraZeneca, with the goal of doubling overall survival for lung cancer by 2025. And one of the ways to achieve that goal, obviously, is early diagnosis. Without early diagnosis, there is no way for cure, which is our ultimate goal here at AstraZeneca. So just talk a little bit about, kind of the lung cancer piece. About 1.5 years ago, which, a year and a half ago, as Prashant has mentioned, we started our collaboration with Qure. And that was because when we went to our countries and said, what is a strategic hurdle that you have, according to kind of our strategies for our different disease areas, that you have no way of solving, not short-term solutions or long-term solutions. And it was very disturbing for us to hear back from many of the countries that early diagnosis of lung cancer, there was no solution for it within the countries. They don't foresee any solution coming out, and it's an issue that they can't solve. So it's because of that we started looking for innovative ways to work within their ecosystem and to identify a solution. And just to kind of give a bit of a perspective on the importance of early diagnosis of lung cancer. One is that lung cancer is the most common form of cancer globally, and it's a leading cancer killer worldwide, accounting for about 1/5 of all cancer-related deaths, more than breast, prostate, and colorectal cancers combined. Each year, more than 2 million people worldwide are diagnosed with lung cancer, and about 1.8 million people die from the disease. Yet, only 19% of people with lung cancer are alive 5 years after they're diagnosed, mostly because they're diagnosed late. Because if you can diagnose early, the five-year survival can be as high as 90%. But only 15 of the patients are diagnosed while the cancer is still localized in the lung. So early diagnosis remain one of our key focus at AstraZeneca as we aim to cure. And we continue to look at various approaches to try to tackle the issue. This year in 2022, we're starting our overlap with TB as we believe in integrated health screening as the right approach. As mentioned by Machika earlier, potentially it can be potentially the most efficient and most cost-effective ways for early diagnosis of many lung diseases, leveraging the different resources and ecosystems to minimize unnecessary overlaps.
Thank you so much, Peche. So I mean, great. I mean, I think I have a follow-up question for Dr. Pillai on this, right? So I think what I mean, before that, I think there's a poll that our marketing team has shared. So maybe I think everybody can answer this poll. Respiratory conditions are the first or second leading cause of care seeking in most primary care healthcare settings, accounting for around 10% of total hospital visits. Second choice is 10 to 20% of total hospital visits. Third is 20 to 30% of hospital visits. I don't think all of us can vote. I think only the audience can vote. But moving on.
Can't vote. Why we can't vote?
It's not. Yeah, we'll continue. So we have to figure that out, how to make everybody vote. But Dr. Pillai, I think, I mean, what Peche mentioned is very, very interesting, right? That we are doing all this screening for TB, and there is so much screening for TB going on, and so many X-rays that are taken, right? How do we, and lung cancer, like she said, I mean, it's something that is diagnosed very late. And so is there a way, I mean, and TB could be one, maybe lung cancer could be one, maybe COVID, right? Maybe other kinds of lung conditions, but is there a way we can look at taking these screening programs, TB screening programs, and applying basically using technology to look at more conditions, more than just purely TB, right? Because this is one thing that I've seen, I mean, and myself, I mean, I got involved with the TB programs about 3 years ago when we were looking at our X-ray solution and how we can work with different countries around that, right? And I saw that from a screening perspective, TB screening is something which is being done across so many different countries in a very organized, programmatic manner. And question is, how do we sort of bring that to integrated lung health and look at other conditions also? So I think that's my question to you. How would you think about something like that?
No, I think that's that's a very appropriate question, Prasant. And I think it's, the reason we're not doing it, I think that's the first question we need to ask, why aren't we doing it? And the reason we're not doing it is actually because the way in which we've set up the health system. We've set up the health system as vertical programs for the most part, even though we say at primary care level, we provide an integrated service. But that's not entirely true. When a patient comes in, you see a patient with whatever the presenting problem is. It's very rare that the frontline health workers will ask an expanded list of questions. And largely because they will say that they don't have the time. There's a long queues outside the consulting room. There is really no time to do an expansive interview. So that's one problem. So the key question is, how do we change the way in which we deliver services? So you have to start with, how do patients understand, or how do people understand their own health, wellness, and illnesses? So you've got to start there. And the more empowered a patient is, the more likely the patient will be to ask the doctor or the nurse to check for other things. I've got a cough, there's something going on in my lungs, I can't breathe properly. So can you check more broadly than just checking for TB, for example? And to the extent to which we make diagnostics, point of care diagnostics, and multiplex it at a clinic level, the more likely the nurse or the doctor will be to do an expanded number of tests on that patient. If we have just singular tests, it's going to reinforce the way in which the service is provided. So we've got to change the mindset of doctors and nurses, change the mindset of patients and communities, and provide them the tools and the systems to ensure that we have real patient or person-centered care. Unfortunately, there's no shortcut to this. Over.
Thank you. Thank you so much, Dr. Pillai. Martin, so how, next question for you, right? FIND had done studies on multiple AI products for detecting TB on a chest X-ray, and had that and got a WHO recommendation for using AI to detect TB on a chest X-ray, right? That's something that was released exactly 1 year ago, World TB Day 2021. So how are you thinking about other conditions in this? How are you thinking about, how is FIND thinking about other conditions? How are you thinking about expanding that recommendation?
Yeah, it's a good point. So it's correct. The policy came out last year, and it says that we can use these artificial intelligence algorithms to replace human readers for TB screening and TB triage. It was a bigger group than FIND. We were Stop TB, it was the International Organization of Migration, it was McGill, it was many, many different clinical partners across the world who kind of came together and provided these chest X-ray archives for the evaluation. So, and we provided data sets on 3 different AI products. But I think where we're trying to go now is to not so much broaden we're also trying to broaden the recommendation, but we are also trying to get more of these competitors. There are perhaps 15 new CAD products that are on the market, and trying to get those under the same WHO recommendation. But there is no mechanism in place to actually evaluate what is a good AI from a bad AI. And there are several publications suggesting that some are clearly better than others. So we're working together with WHO to set up what we call the validation platform. It's sort of a virtual evaluation framework where new artificial intelligence algorithms, or actually new versions of already approved AIs, can then be uploaded to some secure servers taken off the grid, so the AIs do not tell the developers about the images we're looking at. And then we have these highly curated archives with a proper reference standard, and then we can basically push these images through the AI and look at their performance, do a very almost an automated reporting of this, and then present that back to WHO for a PQ policy review. The plan is to launch, I believe it's of course pending WHO, but it will hopefully be already this year. And yeah, I hope that this would really lead to a fast track assessment, so we can really get the quality out there, and perhaps also use competition to drive down the cost. And I think this will be actually the first qualification program for any digital diagnostic. And chest X-ray is the first example, but I think we can use this kind of structure to have many more of these new AIs that are coming out, point of care ultrasound, or Machika was talking about these cough apps, and they are getting quite amazing. I was talking to a developer last week, and they had an AI where you were coughing into your smartphone, a forced cough, something that was really sort of if I would ask my kids to fake a cough, that would be sort of the sound that they were coughing into a smartphone. And then the AI could use that to do basic spirometry. So I think, things that we didn't imagine just a couple of years ago, these are becoming reality. And I think evaluation structures, as we're trying to set up, really will be very important to make sure that quality products reach the consumers.
So I had two maybe follow-up questions on that, what you said, Martin. One was that you mentioned the other companies coming in, building AI solutions? I think there is a poll that has come up right now, but I'll just ask this question anyway. We can do that, so poll can continue. I mean, you mentioned that more companies are coming up doing this, building TB solutions on X-ray, right? And maybe also like cough and so many other different products that are there using AI to improve diagnostics. But are you thinking, I mean, when you're looking at TB, I know that you look at specifically TB, but do you think more companies are looking at more integrated lung health screening where you can detect, let's say, 30 different findings on a chest X-ray? Or are you looking at more people sort of coming in and saying, okay, I want to focus on TB and then do a lot more around TB? That's the first question. Second, maybe I think I'll come to the second question a bit later then. Yeah.
Yeah, I think many of these AI companies are looking into niches, how to differentiate themselves in this space. Few are looking at this broader, looking at, for instance, all of these different, the 35 findings you were mentioning there. Some are looking at pediatric TB. And yeah, I think many centers, they run TB clinics on Monday and Thursday, right? And then there is the X-ray systems there in the other days, right? And why not use that hardware for like the COPD clinic or something else like that, right? And if the AI can capture the pathologies that you're seeing on non-TB days, that would be fantastic, right? And so yes, we are only seeing the beginning of this, and we're focusing on TB at the moment, but we are already now trying to build these archives of like the differential diagnostics for TB to be able to respond to manufacturers who claim to be able to diagnose God knows what on their AIs, right? It's yeah, we basically just need to be one step ahead. We can't be, but we're trying to catch up at least.
Last question to you was, I mean, on this second question, that when you're looking at these diagnostic tools, right, there is, I mean, with AI tools specifically, there is a massive difference between what shows up in a study on a small amount of data versus what shows up in field settings, right? There's always going to be some accuracy difference there. How are you thinking about that? How are you looking at measuring that kind of accuracy or on-field performance? And because on-field requires a lot more things to sort of come together, right? So do you have some thoughts around how you are thinking about a framework to evaluate companies, not only on a data set, which you have already accumulated, but also from a field perspective, studies that are happening on the field?
Yeah, we are looking into these different use cases. At the moment, we're keeping it very, very focused on the two use cases, screening and triage, that the policy was driven by. But clearly, if you get into a primary healthcare setting, the type of TB will be earlier disease. It will be more tricky. You might need to fiddle with the threshold to have a more sort of better sensitivity at a compromise of the specificity, and the algorithms for reflex testing. This is complicated. But yes, ideally we would have these archives to assess also.
Thank you so much, Martin. I think we have a poll, and I think people have already answered the poll. Okay, so we'll moving on to you, Roland. So I think my question for you is about from a tech perspective, right? So what role can innovations in diagnostics, AI, and what role can they play, and what challenges lie ahead of them towards achieving universal lung health, right? So more about the role that AI can play, and what is the challenges that you see from an AI perspective?
Sure. Well, first of all, I think it's great. I think the conversation so far has been fascinating, and I think there are a couple of key areas that I think the cloud will come into play, doing the things that have been discussed so far. So on one side, the development of new AI and the validation of AI is key. And so again, an example is from the Radboud University in the Netherlands. So during COVID, they stood up a grand challenge platform. So they actually put up an anonymized, curated data set into a cloud repository, which then enabled researchers from all around the world to access it in a highly secure manner not only could they access, it was democratization of access to the data, it was also access to all of the AI and ML tools that they could then use, and they could even drop in their own code into the platform and then run it against the data set and look at accuracy. And that Grand Challenge platform attracted 40,000 researchers from around the world to access that data and to develop tools. And so if you want to accelerate the speed of development of these tools and also look at benchmarking, we have these tools already available, they're already working. In terms of that delivery piece, as I said at the beginning, in terms of actually, once you have an AI that's developed, actually getting it out into the field, the other thing that the technology will now enable is that bringing the AI into the clinic. But that, as I said, is only one step. You still need that last mile delivery. And so we've been partnering with Feedback Medical in India to actually do that connection into the field. So that's where clinicians can actually have a platform in which they can upload that X-ray into the cloud, have it assessed by the AI, and have that result fed back into the platform, which can also then do clinical decision support for the caregiver as well. Because once again, it may be that the caregiver, having an AI that diagnoses an X-ray is one thing, having a caregiver that knows how to action that result is another. So I think there are two elements to it. It's not just the AI for the diagnostic, it's also the AI for the clinical decision support to enable the caregiver to really leverage the information to its best extent. And for that reason, we also launched the Diagnostic Development Initiative last year. So the DDI is a 2-year, 20 million commitment to accelerate research and innovation to advance research into infectious diseases. And so, we're offering promotional credits in the cloud and also professional services to selected institutions and companies to look at various areas. So either early disease detection, diagnostics, prognosis, and also public health. And so if there are, interesting, projects that need to be done, that need to be engaged with and help funded, we have resources there, not only with the platform, but also with credits and professional service to enable that to get into production.
Thanks, Roland. I think what you said about getting people to actually use it and teaching them how they can use these technologies is very critical, right? And that's the question I think I was going to ask Peche anyways. How do we set up those programmatic approaches to detect?
And I was going to say, if I may add, sorry,
sure, go ahead.
One last thing, because I suddenly remembered Jürgen's comment about the multiplex diagnostics as well. I think that's a really interesting thing, because again, having single-use algorithms is fine, but to have one data set which many algorithms can use at the same time to assess is really critical. So there's some very interesting things coming through. For instance, GRAIL diagnostics, so circulating tumor markers, where one blood test can diagnose 50 different types of cancer. And so I think that we are approaching a time where single-use algorithms or single diagnostics will give way to one data set being interrogated by many different AI tools to come out with lots of different findings. So I just wanted to add that as well.
I think that is the way ahead for sure. So I was going to ask Peche, I think Roland, you mentioned that, getting people on the ground to start using it, to understand how to use technology is very important, right? And what a lot of times we miss is that we build great technology, but then actually nurses, doctors, general practitioners in the front line have to be able to actually use that to deliver better quality care. So I think my question to Peche was, how do we reimagine a health system approach for tackling lung cancer? And how can these community programmatic approaches supplement this?
Yeah, I think, going into primary care and community programs is especially important. And to your point, right, the system and the new technology really needs to be very easy to use and easy to integrate into the current system in order for it to be leveraged. Otherwise, it's just too difficult. But I think for lung cancer specifically, community programs is especially important, and it's obviously a new approach to detecting lung cancer. And the reason is because, when you have symptoms, when the patient realizes something is wrong and to get checked, it's too late. it's probably have already spread somewhere and it's probably no longer curable. And then we go down on the 5-year overall survival curve, right? So how do we find these patients when no one is looking for the nodules because there is no symptoms and no reason to look for them? And of course, there are lung cancer screening programs, and there's a lot out in literature on how to conduct lung cancer screening programs, but they all require the identification of those patients or those of the population that are higher risk that requires the screening, that should be screened. And all of them right now requires a smoking status or a smoking history at least. But we know, especially here, I think at AstraZeneca, we know lung cancer is not just in smokers. There are many different reasons why someone can get lung cancer, and many of them have no smoking history whatsoever. There's a recent publication that came out, the talent study, that showed many other reasons, especially for some of our geographies, that cancer is not for lung cancer is not for smokers. Things such as persistent exposure to cooking fumes are just as deadly as smoking. And you know, especially in the Asian culture and many of our Latin American cultures, you cook all the time, right? And in a closed environment. So you know, there's many different, but you know, in order to filter enough of the patient population, so you decrease the cost significantly enough to run the screening programs, you're no longer just covering everyone who's at high risk, right? So this is why we feel the primary care kind of system is especially important, because that's where we need to screen when people don't realize they're at risk yet. And we're not asking them to do additional x-rays, right? It's what they're going to do anyway, but to have a background screening and identify those who potentially have the incidental nodules that we can find. And those are how we identify early. Those are the patients that are diagnosed early. It's incidental findings of pulmonary nodules that got followed up. When we first started the project about a year or so ago, you know, the local teams worked with many different types of stakeholders, such as primary care chains, diagnostic centers, and integrating their X-ray machine with the Qure.ai technology and screening the background. And then we've identified consistently 3 to 4% of those patients with no symptoms, no reasons to screen, have pulmonary nodules, 3 to 4%. I mean, when you screen at a large enough population, that's actually a significant number, right? And the lives that potentially, of course, you know, the 3 to 4% is nodules, it's not necessarily lung cancer, but you do need to get follow-up just in case. And some of them are small enough that if you're not looking for it, you won't see it, but the AI technology is able to pick it up. If it is lung cancer, you just get surgery and potentially maybe adjuvant therapy, and you just go to follow up, and your 5-year survival rate is more than 90%. It's not just for the patient, it's for the family, it's for the society, and it's very cost effective, right? Because the amount of investment for treatment in late stage is so tremendous because of, you know, the disease. Now we're very good at coming out with new innovative kind of medicine to treat these cancers, but these are also expensive treatments. And these patients are mostly toward the end not contributing to society anymore because they just can't, even though they are still on treatment, but the treatment sometimes can be very debilitating as well. But if you detect them early, they get the treatment, the adjuvant therapy is usually not very significant in their side effects and all of that, and they go back to work, right? The cost saving for the healthcare system is potentially very, very big. And obviously we decrease the death rate for meeting the WHO of decreasing the non-communicable disease death rates, right? So all of that, we just really need to start in the primary care setting.
Thank you, Peche. One of the takeaways I got from that is we should not be cooking at home.
Good release of fumes for sure.
So thanks. I think it made a lot of sense, and there is a poll coming up, and I'll also invite the audience to ask any questions if they have any, because I have some more questions, but we don't have too much time. Is there a question? I think one of the questions Dr. Yogan Pillai had asked about to Martin was about this cough app, and is that, I mean, all these cough apps, are they ready for use on the field? Are they validated now, or they are still being validated?
Yeah, they're still being validated. But you know, it's the wild thing about these new digital tools on smartphones. You just put them on an app store and then they're there. The challenge is to make sure that they actually work. So yeah.
And these are tools which can detect, I mean, based upon the cough signatures, they can tell you whether it's TB or some other condition. Is that?
Yeah. Yeah, so some are designed in a way where you basically have your smartphone or your smart speaker next to where you're sleeping, and then during the night it counts the coughs and look at the quality of the cough. And you can imagine if you were an asthma patient or a COPD patient, that just constant monitoring of your cough frequency and perhaps some of the finer details of the individual coughs, that could inform whether you are, you know, getting an exacerbation of your symptoms and need to seek care. And you'll probably be able to pick that up earlier than if you were just looking at yourself as a patient and managing yourself. So it might be the app would pick it up earlier and or do individual dosing of your medication. Yeah, many new opportunities there. But of course, the diagnostic use case is tricky, right? These are probably screening tools that should trigger health-seeking behavior.
No, absolutely great. I mean, I think that's great. I mean, I think it'll be very, very useful on the field whenever these technologies are available. There is a question from Ankit on what more can be done to build more patient empathetic technology. So I'll ask Roland maybe to answer that first, and I think everybody else can also answer that.
Great. I think that's a great question, and I think that goes really to a lot about health equity. So how do a lot of the technology that's coming out has to be consumable by everybody, no matter what their technology level, and also using the technology that they actually have to hand. And this is especially problematic in low and middle income countries, where perhaps the infrastructure is not as good and that last mile piece is much harder to overcome. We have been working, there's a lot of work underway with different groups around developing better front ends to really enable patients to access care more seamlessly. And a great example actually comes from South Africa, where we were working with Prikelt to deliver a WhatsApp engine. So it was a WhatsApp front end for mobile phones, powered by AWS in the back end. And that linked patients to various different healthcare services, particularly maternal services. And it was automated at the back end, so it routed people to the correct services at the appropriate time. And that has actually been taken up by the WHO, and it's also a similar system used but for GovChat in South Africa as well. So these services can be used by people with a mobile phone, and also during COVID, various chatbots were set up that actually were able to, if people didn't have a mobile phone, were actually able to make calls to landline telephones as well, to also, and then have actually a voice conversation to look for needs of individual patients who had already been screened by AI to be found to be at higher risk of problems from COVID during the pandemic. So I think there's a big move here. I think there's a lot more to do, but certainly there's a real lens on how to make this technology accessible and equitable.
Question for you, Peche. What's the one thing, according to you, that we need to do ASAP to make quality lung health a reality for everyone?
I think now is the time to kind of think about new approaches to health screening. I saw a comment in the chat as well saying that TB is a curable disease, lung cancer not necessarily, and that's why they've always been separate, right? One is in infectious disease, one's in cancer, and one in oncology. So they're usually not combined. And it's because usually the diagnostic tools are different, and the approach and the process for patients are different. But now we have new technology that's able to do more than before. And it's now the time to kind of consider new different approaches that we've never considered possible before in order to integrate some of these resources and some of the ecosystem that already exists so that we can leverage each other and provide better kind of care for our patients and early diagnosis for many different diseases.
I think, I mean, that was a very good point that you made, right? I mean, TB, I think somebody said that TB is curable, but lung cancer is not. But do you think, with early diagnostics, it is curable right now with the drugs that are out there in the market, or?
Yeah, so if lung cancer is caught early enough, if it's just a nodule, has not spread, literally you just cut it off, right? And then if you're worried that it has spread a little bit, you do adjuvant therapy to make sure you kill everything else, all the other cancer cells that was not able to be removed. But if you're able to catch it early, our 5-year survival, and 5-year survival a lot of times is what we use to kind of tentatively say cure, right? Because if 5 years, the cancer hasn't come back, you have a very high likelihood that you'll maintain that for a very long time, right? 5-year overall survival, if you diagnose very early, it's above 90%. So it's definitely taking us a lot closer to cure if we diagnose early than waiting late. If you wait late, it's impossible to cure.
That's a great reason to be able to diagnose early and to look at integrated approaches for screening, right? So I think, we have so many people from different backgrounds here who are running these kinds of screening programs for lung cancer, TB, and FIND, who's looking at diagnostics, and AWS, which is basically enabling all of that to happen through a technology infrastructure that they provide. I think there is an opportunity to bring all of that together. So I think that's a great point. Any other questions from the audience? I think we have a couple more minutes remaining.
Can I ask one? One of the theme of this year's World TB Day is investing in TB, right? And as I think we all know that from the assessments that have been done by WHO and others, that we short about $1.1 billion annually in the TB space. So the key question is, how do you raise $1.1 billion each year for the next decade or so? If we don't do that clearly, according to the estimates, we're not going to get on top of this TB thing, right?
I think, Martin, you wanted to answer that?
No, I raised my hands not because I have an answer to that one, because that is the $1 million question. But I think we need to acknowledge that we are in a very, very unique time just now. We're coming out of the pandemic in some parts of the world, and the past 2 years have just been a massive investment in hardware, in diagnostics, in vaccines, and treatment. And I think there is momentum now. And that momentum will be lost in a couple of years, where investors will go outside of health. It's now we need to take the best of COVID, bring it into TB and other related diseases. It's there for the vaccine developers, the diagnostic developers, the treatment people. It is there at our fingertips, right? So I think, yeah, this is what we need to do. And that's why investing, I think, is the theme of this year's World TB Day.
Yeah, I completely agree with that. And I think, I think I completely agree, first of all, that the time is right to springboard off what has been done with COVID. I also think there has been a fundamental change in the technology backbone that can actually be brought to bear as well. And I think that last month, I genuinely think there has been a fundamental change in the way that care can now be delivered at scale. So I think there's an exponential aspect to this that we should be leveraging. And hopefully some of those costs will be brought down. Of course, a lot of these costs aren't technology costs, they're actually human capital, and it's actually people on the ground who are doing the doing. But hopefully some of these costs will be brought down and and be democratized. And certainly that's where we are looking to lean in and support these initiatives that are taking place at the moment. So it'd be great to connect offline and work out how we can come together to maybe solve some of these questions.
Peche, you wanted to add something?
No, I was just gonna say, definitely, I think there's a limited amount of resources, right? And more the reason to integrate some of these things so we can leverage each other's resources and avoid duplications. And potentially some of the savings that comes from it can be reused, right? Moving from late disease to early disease, it will be a lot of cost savings. And definitely, I think for lung cancer, governments are investing into lung cancer care, lung cancer screening. If we're doing it together, there's resource for both, right? And we're doing that both together. And there's a comment also in the chat that definitely I think the treatment is different and all of that. And that's why the different referral system need to be set up. And it's really requiring kind of another different way of approach to our healthcare system so that there's a screening, but according to what is fine, that patients are referred to different places so they can get the best follow-up assessment as possible. And then we can leverage those savings for things that's now not being taken care of.
Thank you so much. I think we are at the end of the hour. Dr. Pillai also has to drop off now. So thank you so much. It was an amazing panel discussion. And we heard from people who are actually running on ground. Dr. Pillai was running on ground programs, to Martin, who is finding diagnostic solutions, to Roland, who is basically building the technology to deliver those diagnostic solutions, and from Peche, who is actually building the drugs to cure those diseases, right? So great to have you all on the panel. Thank you so much for participating, and look forward to working together on creating this integrated screening approach. So